eHarlem TV is brought to you by Mount Sinai Medical Center, Digital Laundry, and the Fresh Bread Group, and with the generous support of the Peter and Carmen Lucia Buck Foundation.
We have a very diverse country, and so we need to learn how to take care of very different types of people with different customs in terms of food, people with more challenges in terms of what they can afford in terms of healthy eating, whole problem of access to care where if people don't have insurance or they don't have high quality insurance, they can have trouble getting good care. And our whole healthcare system really isn't set up right now for us to really think about how can we give the best possible care to different types of people.
A lot of people don't realize that these disparities exist, and they don't believe that they're creating them. And they refuse to acknowledge that despite how well educated that they are, that their unconscious biases are coloring the way that they deliver care.
Inclusion is basically making everyone feel as if they were valued, respected, appreciated, and ultimately, it's treated with dignity and respect so that they can feel that they are part of a community.
Why does it matter? I would say there are two important pieces. One is not just ensuring, obviously, that the patients understand how to take care of themselves after they leave the facility and ensuring that they don't come back because we didn't communicate effectively or appropriately. Two is that their experience ultimately is going to influence how they rate us in delivering their patient satisfaction scores.
Healthcare professionals from across the country gathered at New York's Desmond Tutu Center to discuss issues relating to disparities in the delivery of patient care and to share strategies for addressing them in our extremely diverse society. My co-host Fred Noriega and I had an opportunity to sit down with some of the speakers and attendees in order to gain a better understanding of what the issues are, the challenges that the medical field is facing, prescriptions for moving forward, and their prognosis for the future.
To go against the cultural grain of treating our healthcare providers as authority figures and being empowered partners in our care.
In this month's episode of eHarlem TV, we share with you some of their thoughts.
But part of the problem is that physicians and practitioners out there just don't believe it's happening. And so it took this commission, if you will, to examine just exactly how extensive these disparities were. And here's what they found. They found, after looking at mountains of evidence, that even after you adjust for age and severity of condition and even insurance status, people of color and other minorities were getting the worst care.
Basically, what we know is that some patients can navigate through the system and successfully come out of the system with better results than others. And often we find that this is a result of the population demographics or their ability to understand health information and process it. And there are so many variety of factors that can influence how a patient understands their health care and understands the complexities of the health system. My job is to work not only with the patients, but with the healthcare providers to try to simplify the system so that they can more successfully get through them.
But it's more than just financial access, because even when people have financial access, they're not getting equal care. So we need to do a lot more to educate our providers. We need to introduce systems that match up patient demographics with patient outcomes. So as one quick example, less than 20% of American hospitals collect patient demographic data and tie it to patient outcomes.
There's a national report that the government comes up with every year that looks at our nation's healthcare quality and disparities. And year after year, we find major differences in the quality of care and the outcomes of care people receive based upon factors such as race or ethnicity, insurance status. These are unacceptable disparities that we need to work on.
The not me phenomenon is very powerful, and part of that stems from the fact that when you're talking about issues related to race, ethnicity, issues that are charged, right? It's not patient safety. Patient safety is something we could all rally behind. It's kind of a neutral issue. But when you're talking about race, when people hear disparities, they assume immediately that if you're saying they have disparities, they're discriminating. And it's a different conversation. I mean, part of what we know about disparities is there's a lot of reasons for it. And so people's first response is, no, we treat all our patients the same. We treat them all well, and we don't have any disparities. The interesting part is if you ask them, do they collect data to support any of their statements, you'll see 9 times out of 10 that they don't collect the race ethnicity data and they don't have the evidence to back up what they're saying. And I think that's what the challenge is. How do we get people to put their money where their mouth is? If you have no disparities, then let's just collect the information and monitor and measure routinely and make it part of the quality fabric. So I think that's the challenge ahead.
Well, culturally competent is actually, I'm not sure that you can put sort of a clear definition that says this is where it begins and this is where it ends. It is how a patient wants to experience their care from beginning to end of their care. So I would suggest that cultural competency isn't something that you can put in a box and say, I'm done. It is an ongoing experience about how a person, in some cases, more than prefers, but oftentimes requires that they interact with other individuals and how other individuals interact with their children and their family members. But the foundation of cultural competency is treating others the way they want to be treated, which means you need to understand what they want, whoever they might be. And if they, as a patient or a family member, treating them the way that you want to be treated, perhaps in your religion and your culture and your language, may not be appropriate in patient care for the patient. So the whole foundation of respect, treating others the way you want to be treated, would suggest that I'm willing to do this. I'm willing to respect you. But in order to give you culturally competent care, I might have to ask you what that means. And that also might mean I need a tip that's called be flexible. That might mean I need to do something a little differently because what you need is very different than what I would want or need if I were in your place. So there's a big difference between treating others the way you want to be treated, which is basically foundational of respect, and treating others the way they want to be treated really is going to, vary by the patient, by the employee, by generation, by disabilities, by sexual orientation.
There are efforts to diversify workforce. I think that's an important component of culturally competent care. I think that in some ways it's unrealistic for us to think that we're always going to be able to find somebody that's like ourselves. However, I think that there are lots of efforts to try to expand the pool of available prospective employees and healthcare professionals that are from different diverse communities and backgrounds. So there are efforts being made, which is a positive. And yes, in certain areas, it's hard to find people who meet the qualifications or have the experience. But a lot of organizations are actually working to invest in their own employees because maybe the people who look like their patients may not be the ones that are providing the care, but they're working in that hospital or they're working in that healthcare system. So it's working with them to try to create programs where if they want to, and many people do, they want to go back and receive additional training. Many people decide to be employed in a healthcare system or a hospital because they want to be part of caring for people.
When I use that term, cross-cultural healthcare, I'm really talking about 3 key issues. Racial and ethnic disparities in the quality of care. And all the best evidence suggests that people of color in this country get the worst quality of care. Second issue we're talking about is language access issues. And people who speak other languages, as 20% of the American population does today, have a legal right to an interpreter to be heard and to understand their physician. And the third issue we're talking about is medical disparities that result from globally mobile populations.
That if you don't speak English, you have a harder go of it in terms of getting good quality care. If you are poor, you have more trouble accessing quality care. But also, the healthcare system, we don't tailor our care good enough. So in other words, say someone with diabetes, every patient's a little bit different. Everyone has their own set of challenges in terms of doing their exercise or eating healthy or affording and taking their medications. So we needed to think about how can we build ways of delivering care to people that individualize to the specific challenges that different people have? And how do we pay for that? And how do we create incentives for doctors and clinics and hospitals to create these better systems of care?
Please visit us on the web at eHarlemTV.com, where you could tell us what you think about our program, as well as access any of our stories.
We did a study recently that was published in 2010 that actually looked at how hospitals were complying with standards that are supported by law and regulation. And I have to say, the results weren't terribly encouraging. And these were standards specific to language access. And that's why I think it's really important for patients to know that they do have a right to an interpreter. And the study showed us that, only 13% of the 260 some hospitals across the country that we surveyed were actually full spectrum complying with the standards. So an example of not complying with the standards is the fact that many of them are still relying on family members and friends and people from the waiting room to interpret for patients. And that's not fair to the patient. And it's really also not fair to the provider, because that provider wants accurate information.
There's a cultural dynamic that's underlying as to what may be appropriate to ask you, or am I supposed to ask the husband, or am I supposed to ask the family? And in some cases, simply understanding language doesn't mean you understand culture. In some religions, the sickness is communicated by the family and not the physician. And so you can't go back and say, sorry, I didn't mean to say that. And in many cases, we make these mistakes unintended. So let's just assume that English is your first language as the communicator, and Spanish is your first language as the receiver or the patient. So I suggest to you that I want you to take this pill once per day, and I want you to take this pill once 3 times per day. Now, out of respect, I've said it to you out loud, right? And now you didn't understand what I said, or maybe you did, but you go home and you read it. And the prescription says to a Spanish-speaking and reading person, ONCE per day, ONCE 3 times per day. Now, to the average person who speaks English, that means I'm going to take 1, and I'm going to take 1, right, 3 times per day. But if I'm Spanish-speaking, I'm going to take 11.
Particularly in areas of the country such as New York City, where there are thousands and thousands of languages spoken, there's a reasonableness to the expectation for finding an interpreter, especially a person who's going to be there with the patient to interpret. Diversity plays a really large role in language services from multiple perspectives. Professional interpreters are not only trained in the language, they're trained to understand how to take the meaning of what a patient is saying and communicate it to a provider. They follow a code of ethics and professional practice standards that guide that. Part of that is also really being attuned to that patient's culture, because culture with a different language also likely comes a different culture. We all hold within us our own set of personal beliefs and things, but professional interpreters are also trained and attuned to better understand the patient's cultural needs that they may bring that may be attached to that language. So that's, I think, one way in which diversity plays a role in language access. As I mentioned, the reasonableness clause, because it's unlikely to expect that every healthcare organization or every hospital is going to have an interpreter available in every single possible language that presents. But hospitals should know who comes through their door and make some accommodation. Sometimes it might be an interpreter that's available by a telephone, or an interpreter that's available by video. But really, because of privacy rights that patients have, as well as their need to accurately give information to their provider as well as receive information from their provider, they want somebody who's trained. It's very interesting to ask people, in health professionals even, to do repeat back exercises that involve something that they're not familiar with, such as, how to, change a carburetor or do something like that, using language they're not familiar with. And even from English to English, it's often very difficult for them to remember the words. So if we add in the need to interpret and change that to a different language, it becomes more complicated, thus showing the need to have somebody whose skills have been honed in to be able to do that very well. And patients, I think, need to recognize that professional interpreters are part of that healthcare team. And they're there to serve that patient, as well as to be part of the team in support of the care that's being provided to that patient.
I think if we look at first a deaf person who communicates in a sign language, and typically they'll go to a medical center or a doctor's office and they'll tell them they need a sign language interpreter to effectively communicate. Even though the Americans with Disabilities Act of 1990 should protect their rights and ensure that they have effective communication, it's still unfortunately not uncommon for a physician, for example, to say, I'm sorry, we don't provide interpreters, or bring a family member. And it's important to have effective communication, which means using professional interpreting services. If that doesn't happen, patients are not getting the information that they need, they don't ask for clarification, they don't understand instructions, so their health, their outcomes are going to be affected.
But does that also mean that if they don't have someone to sign for them or interpret for them, that they may go home without care?
Absolutely. They'll go home without care. They won't return very readily. There's overuse of emergency rooms, which is not a good practice because they know that at least if they go to an emergency room, they'll get an interpreter. So it definitely has an effect on follow-up, on medication adherence, on outcomes. It's also, I just want to add that the research shows that if you don't have effective communication, there are longer length of stays, there are more readmissions, more emergency room visits, more unnecessary diagnostic tests performed, lower patient satisfaction, worse medication adherence and compliance with appointments, and overall not as good outcomes. So we know this.
It's new, exciting, and important. eHarlem TV. Our guest, first-term Assemblyman Robert Rodriguez.
Anything that requires public land or public dollars with respect to housing should be affordable.
8 years ago, had an East Harlem initiative to promote tourism. Did it help out?
Initially, we had some success.
Todos van a brillar como las estrellas que vemos arriba.
eHarlem TV.
We need to think about the different targets and different underlying areas we can work on. So for example, in terms of the patient and the doctors, well, there's a lot of talk in terms of trying to improve communication between patients and doctors. So, they're speaking the same language in a sense, and so that the doctors aren't sort of speaking medical language all the time and not understanding the actual challenges that patients have. And so this whole area, providing culturally competent care, that's part of it. But that's not enough. That we need to think about what can we do in terms of improving then the system of care that doctors work in and the way things are paid. So systems, I mean, doctors tend to work in clinics or they work in hospitals, and then a large part of the care really is affected by the way that that clinic or hospital is organized. I'll give you an example. There's a lot of evidence that team-based care, where the doctor works with nurses and educators and social workers and perhaps community health workers, team-based care as a whole does better as opposed to when it's just that one doctor and that one patient. And why is that so? Well, in a team-based approach, people have more time, more time to talk to the patient, more time to counsel the patient, more time to work with the patient in between visits. So for example, most of the time the patient's at home or in the community. And so there are ways, for example, to use telephone-based care, to try to check in between appointments and basically help people out of the emergency department, out of the hospital. So I talked about the patient communication. I talked a little bit about the clinic and the organization of care. The other big factor is policy and the financing of care.
There's been a real revolution in our understanding of the science of bias, and we now understand the big breakthrough here is to realize that our biases are not conscious and intentional, but they're largely unconscious and unintentional. But the law only recognizes conscious or intentional discrimination. And that's where I think the law needs to change, and I think that that's where medicine needs to change too. That we need to understand more about how unconscious bias affects the way that we offer care.
Disparities is an issue where the government, public policy, public opinion can make a huge difference. Okay? So first of all, I mean, for the public, that it's really important to make sure that your congressmen, your senators realizes this is an important problem and an unacceptable problem. I mean, when there's public swelling for this type of movement, you see things like the Affordable Care Act being passed, where you see things like provisions for data to be looked at by race and ethnicity, where you see there being funding for innovative programs that can work on reducing disparities. And so clearly, in terms of creating an environment where people realize it's important and that there's funding to do innovative things to reduce disparities, politics or policy or public opinion can make a huge difference.
What we understand certainly is that the healthcare system is going through a lot of changes. The healthcare dollar is being split in many, many different ways. And so people need to know that if they invest in an intervention, in something to make a difference, that they are going to get a return. And when I mean a return, part of that return could be better quality health, but it also needs to be tied in some ways to the bottom line. And I think we can align those. You know, by doing well by people, you do get a return on your investment. And I think that's what we're trying to do, is demonstrate that if you got $1 to give, you know, if you know that if you put it behind this intervention, you know, you're going to get something out of that dollar. And that's what we mean by the ROI in healthcare. The solutions are all there. The barriers are, number one, you have to collect race and ethnicity data to know where to deploy your intervention. When you don't collect it, you could say, we don't have any problem, what's there and why is there a need for a solution? Number two, if you do identify a barrier, what you see is a need for resources, motivation, and energy to carry that out. Resources are tough to come by nowadays. We're competing for a lot of resources. So one of the major barriers is getting people to invest in these interventions. And then, if you have 7 different interventions, you want to figure out which one is most effective, which one is going to give you your return on your investment, which one is going to give you the most value for that dollar. So we need to be calculating that as well. Because then at the end of the day, we could say, look, this intervention works, it affects the bottom line, and it improves the quality of care, so it hits on all cylinders. That's where we need to be going.
I think something positive we can say about where healthcare organizations are in terms of this continuum of providing culturally competent care is that they are improving. But I also would say 2 additional things. There's a lot more to do, and the journey is never going to be over. So as I have had the opportunity to visit and really understand organizations that are tackling these issues, the ones that do the best and the ones from whom I get the most consistent message, no matter if I'm talking to the receptionist or the physician or nurse, are the ones whose administration and everybody in the organization says, you know what, we're doing some great things, but we have so much to do. And they're the ones that see this as a continual journey.
It's a mixed picture where we're doing better on some things, worse than others, about the same for a lot of things. Overall, we're about the same, maybe slight improvement, but overall, a long way to go. Yeah. It's going to be a gradual process, but I'm actually quite optimistic that I think that if you look at where we are now, as opposed to, say, even 6 years ago, we are much further along in terms of first people realizing this is a problem, that we need to act. And then there's both the government as well as a whole variety of private foundations and private players are spending more time on this. And the first step in some ways is basically showing people that there is a problem.
I'll say that the last 5 to 7 years have been incredible, and that we've seen a lot of movement, a lot of energy, and we've had real key research that has begun to tie these issues to the bottom line. I expect the next 5 years we'll continue to see that research. I think we'll begin to see organizations get more serious about this issue, and I think accrediting bodies will move this from the optional column to the mandatory column. That's when I have a sense that we'll really know that we've arrived and we'll begin to make a difference in earnest.
The conversation about paying it forward or inclusion in patient care isn't an option. We have to get this right.
And as far as I'm concerned, I would love to see hospitals and clinicians do it for the ethical and moral and right reasons. But if they do it because it's the law and it's a requirement, I'll go with that too.
The Affordable Care Act that we just enacted, Obamacare, if you will, I think will go a long way towards remedying some of that financial accessibility. I've taken patient satisfaction data broken out by race and by language to hospital CEOs, and I've had hospital CEOs look me right in the face and say, that data will never come out as long as I'm the CEO of this institution. And on the other hand, you have some hospital CEOs who are being tremendously courageous and are insisting that precisely that data needs to come out. It's precisely those stories that we need to hear if we're going to change this.
It's about awareness. It's about behavioral changes. It's about teaching people what they can do on a day-to-day basis in order to make people feel included who are from different walks of life.
Candy Castleberry Singleton's Dignity and Respect campaign has spread from the University of Pittsburgh Medical Center to hospitals across the country. She challenges professionals everywhere with her favorite quotation.
It's funny because that's an anonymous quote that I read someplace on the plane, but I've been saying it for like 20 years. And so once one of my employees saw it in a book and it said anonymous, and she thought anonymous was me. Because I've said it for so long, I think many more people have probably heard it from me than from the person who actually said it. But it goes, this is the beginning of a new day. You've been given this day to use as you will. You can waste it or use it for good. When tomorrow comes, this day will be gone forever, and in its place, something you left behind. And then I ad-lib. Let it be something good. Let it be something that supports inclusion. Let it be something that raises your consciousness about how cultural competency impacts patient care. Let it be something that raises your consciousness to realize that what you do every day does impact people. And let it be something that encourages you to think about how dignity and respect can be a part of what you do, not just in the workplace, but in communities and schools.
eHarlem TV is brought to you by Mount Sinai Medical Center, Digital Laundry, and the Fresh Bread Group, and with the generous support of the Peter and Carmen Lucia Buck Foundation.